Good day, my dear undergraduate and emerging postgraduate students. I welcome you to What Next. Please look at the picture on the screen. I see a central area of congestion and some cotton wool spots. Perhaps the diagnosis is typical. Let us go to the clinical history. A 58-year-old male came to the hospital with complaints of severe headache and gradual diminution in vision. There was no history of drug intake. On examination, the ophthalmologist confirmed diplopia and dimness of vision in both the eyes. It was more prominent on the left side. The blood vessels were tortuous on the face and a biopsy was taken from one of them. In addition, the patient had given a complaint of difficulty in mastication. As mentioned, the BP was normal. ESR, however, was raised 56 millimeters per hour. Other hemogram parameters were found to be normal. The patient was immediately started on steroids as there was no clinical sign of infection. What is your diagnosis? As I told you, concentrate on the keywords. So a biopsy is being taken from a blood vessel. Recall the subjects that are involved in this clinical case. The disease can be called as temporal giant cell arteritis or Wegenous granulomatosis earlier, but now it is called as granulomatous disease with polyangiitis. What are the clinical presentations? One, there is a vision loss because the optic nerves are being affected due to retinal artery occlusion. There can be a condition called as amaurosis fugax. Diplopia can be there as well as the cranial neuropathy and orbital inflammation. Either of them can be contributing to the diplopia. Vascular occlusion can be leading to a necrosis in the scalp in the temporal region. General systemic manifestations can be present. Jaw claudication, it is an important feature. That is why I said there was a difficulty in mastication. There can be the limb claudication as well as myocardial infarction in some cases, but these are rare. So therefore, we will be concentrating on the main features on the upper part of the screen. What are the criteria for diagnosis? Age. Patient is more than 50 years. He responds to steroids in 48 hours. History, more than 2 weeks duration. Positive temporal artery biopsy. Proximal symmetrical girdle, upper muscle pain and tenderness. We had seen that in the picture. Jaw claudication, temporal artery thickening and tenderness. Malaise, anorexia, weight loss. Headache, visual disturbances. And this is how we should read the criteria. This is from Ellis and Ralston. In summary, the diagnostic criteria can be age more than 50 years, new onset, headache, temporal artery abnormality in the form of palpitation as well as pulsation and thickening. ESR is raised and abnormal temporal artery biopsy. At least 3 of these should be there for diagnosing the so-called giant cell arteritis. Now, what is the schematic diagram showing us? It is arteritis. Some books call them vasculitis. So, there is aorta, the largest artery, and then there are some large blood vessels from which we can think of temporal giant cell arteritis and Takayasu's arteritis. Then there are the medium-sized blood vessels, such as the renal artery, in which we can be having polyarteritis and Kawasaki's disease. Later on, you will be having the small arteries, from which we can be having the microscopic polyangiitis, venous granulomatosis, and Churg-Strauss syndrome. Finally, you can have the arterioles, in which there can be hinox-condylar purpura, cryoglobulin vasculitis, etc. So this kind of a scheme we shall be seeing repeatedly. This is another method of classifying the vasculitis. Large cell, giant cell, temporal, Cogan syndrome. Medium-sized polyarthritis, Burgess, and primary CNS disease. Small cell, ANCA, anti-neutrophilic cytoplasmic antibody with small cell vasculitis. Granulomatous, formerly called as Wegener. Microscopic polyangiitis, Churg-Strauss syndrome, drug-induced, Behçet's disease, hypersensitivity, urticarial vasculitis. These can be in very small blood vessels. And see what is over here. There is an involvement. This is a lumen over here. And then immediately in this region, it is the intima. Then there is a media over here. Externally, there will be the adventitia. There is an inflammation spreading from the intima up to the adventitia. Also, I'll be able to see some giant cells. That is why the word giant cell arthritis has been used. Most of the infiltrates are lymphocytes, and the lumen appears to be compromised. So this is the histological picture, which is mandatory in making a diagnosis. See you in what next?